My name is Dr. Love. I'm a consultant gynecologist and obstetrician. I welcome you all to today's meeting, and I'll be presenting the topic that says recognizing warning signs in labor room, when to intervene. So these are my outline: introduction, intrapartum monitoring, clinical method, biophysical method, CTG, and conclusion. So as a word of introduction, the uterus, as a layman will call it, the womb. Me, I call it the best incubator ever. The best. There are not two of them. You know, sometimes a woman will tell me, "Doctor, I'm tired. I want to deliver baby. I say, this incubator is the best, though. Just be patient, okay?" So I also call it the powerhouse. President General. Uterus, I believe it's the baby that is the best person to describe it, but I can just imagine. Uterus, God has made this piece to bring life to this world, and it's a beautiful piece, a beautiful creation of the Lord. So, but there are benefits of the uterus. The baby, when it's in the womb, of course, is the best for the baby. All expense paid. You know, baby gets everything, vitamins. Sometimes a mother will tell me, "Doctor, what will I be eating?" So that I will tell them, don't bother about the baby. He knows how to fend for himself. Okay, the uterus supplies everything to the baby in right proportion. At times, I will even call the baby a parasite. Even if the mother doesn't have enough, it takes what is available and keeps itself going. Okay, but at times, there are times when the fetus will begin to say, "I can't breathe. I can't breathe." And what do we do? That calls for us to intervene. Our topic today is going to let us know when there are challenges, warning signs, when the baby is raising an alarm and saying, "I am no longer comfortable here. Can somebody help me?" Okay? This is what we're going to discuss today, to see what we can do for the baby. Do we let the baby continue to stay inside, or do we have to deliver the baby? Then the obstetrician and the pediatrician will now put heads together and begin to weigh it. Is it better to keep the baby longer, or do we have to bring it out urgently? That is what we are going to discuss today, to know when to intervene, how to identify the warning signs that the newborn is not breathing well, and how we can bring help to the fetus and the newborn. So that is to say that all that glitters is not good, in as much as the womb is the best incubator, but at times it can be uninhabitable for the newborn or the fetus, and we'll have to let the baby come out. So labor is also a stressful event. Contraction shuts down supply. I can't begin to analyze or explain. You know, the womb or the muscles are intertwined like this with some vessels. When there is contraction, there is a squeeze, and when there is relaxation, there is a supply. When there is contraction, there is a squeeze, and when there is relaxation, the flow is better. So this takes about 90 to 150 seconds to recover. There are times there may be cord compression or cord compression. For some reason, maybe the cord is just by the baby's head, and between the head, this is the womb by the side, and everything, the cord is being compressed, and you'll be seeing the baby saying, "I can't breathe, I can't breathe." So other times, the strength of the contraction may be just too much, or it's coming more frequently. It's not giving time for the womb to relax, for the baby to breathe, and before the baby catches some breath, another contraction is there. Before the baby another one is there, back to back. Okay, so this is what we're going to discuss: how to identify it and how to help the baby and the mother. So we are here, and also it's good to identify the risk, just like the first speaker had said. Sometimes the signs might have started antenatally, or even before the woman comes. So it's our job to identify the at-risk baby and bring help to them. So that brings us to intrapartum monitoring. The aim of monitoring a woman in labor is to do what? For early detection of distress on the fetus or the mother. So it also helps us to determine when to intervene and the type of intervention we are giving. Are we going to just resuscitate the baby intrauterine, or are we going to bring it out immediately? That is the aim of monitoring. And in all of this, we want very minimal or no harm to the mother and child. Okay, so the monitoring also, like I said, my chief had discussed about the antenatal monitoring. Okay, when a woman comes to you in labor, you first of all go through her record. What's her history? Is she hypertensive? Is she diabetic? Is she a sickler? Is this rhesus? Is it, you know, all of that. You should have known about that before or when she comes in labor. Also take the history of the labor. How long has it been? Has your baby water broken? You know, all of that. Do you have fever? Did you see blood and all of that? How frequent is your contraction coming? These are the things you ask this woman to classify her where she belongs. Okay, having done that, we now decide what mode of monitoring we are going to give this woman. We either group them as low risk or high risk. For the low risk, we can do routine monitoring with maybe, I'm going to discuss it soon, or we can even go to the advanced level. The clinical methods of monitoring include intermittent auscultation of the fetal heart and even observation of the amniotic fluid. For the auscultation of the fetal heart, it's usually the commonest method of fetal monitoring and the oldest form of it. Okay, believe everybody that has been in the labor room must know how to do this. Okay, so we should have taken our history, examined the patient, and classified, okay, this one can go for this one cannot go for this. And we listen. This is the number one thing we do, almost always, even in antenatal. There is no woman, once you are 20 weeks and above, that you come, it's either they listen or they use the Doppler and listen and see how well the baby is doing. Okay, we listen during or after contraction. We do mostly listen after contraction. What you must know how to relate it. Sometimes my medical officers will call me, the heartbeat is going down. It's down. I will be like, calm down. Don't go down with the heartbeat. I will ask you, when you checked it, was she contracting? Sometimes, like we said, when the uterus is contracting, it's squeezing on everything. The heartbeat will drop now. If now you, they come hug like that inside the womb and squeezing you with the contraction, of course your heart rate will drop a bit. So we ask you, was she contracting? When you checked, you'll be like, yes. I say, okay, calm down. When the contraction has waned off, can you check it again? They will check and be like, oh, it's not normal. I say, you see. So you monitor, but you must relate it with the circumstance. Is it during contraction? Is it, even in second stage, sometimes you see a normal heart rate, and at second, when the woman is pushing, you are getting 19 beats and everybody is rejecting. I'll be like, if now you, they squeeze your head for that tight corner, why you no go cry for help? Okay, but the point is that we must know how to do this and be very sure and confident of how our mode of monitoring and relate it with the clinical circumstance and make a very good decision for the baby. So we also, another method of monitoring is meconium staining of lipo. I must quote that we don't use this in isolation, okay, to decide whether a baby is in distress or not. We must first of all know the causes of, baby. This meconium is baby poo. For some reason, a baby poos inside the baby water and it changes color. That's what we call the meconium. Then you have to check the color of the meconium. Is it fresh? Is it stale? Is it puree? There are ones that are very concentrated, and we are afraid that if the child aspirates such meconium, there may be some complication. Okay, but the point is that you don't use it in isolation. You must marry it with the clinical circumstance. When you see a postdated baby that has passed the EDD and is meconium stained, would you be worried? For me, I would be worried, and other times I wouldn't be worried. If every other thing is okay and it's just the meconium stain and it's very light, not very thick, you can do watchful waiting. Then other times when there are other things that come with it, it calls for early intervention. A few causes of meconium stain like chorioamnionitis, rhesus immunization, preeclampsia, postdated pregnancy, and cardiovascular malformation. These are things that can give us meconium stain like and when you see such, you marry it with the clinical circumstance of the woman and see if that baby that is crying for help really deserves to be delivered. So we have biophysical method of monitoring. The electronic ones, we have the indirect and direct one. The indirect ones are the phonocardiogram, the ultrasound, the fetal ECG that's, doing ECG for the baby from the mother's abdomen. And we have the direct ones that we can apply directly to the baby, the clip, the spiral electrode, the other methods like scalp stimulation, vibroacoustic stimulation, monitoring uterine activity, the tocodynamometer, and the indirect through the intrauterine catheter. These are methods of fetal monitoring, but all of them, they do not apply to same everybody. It varies, depends on an individual. The invasive ones, we must be very careful when to use it, and that brings us to checking on the patient, taking history. For somebody that has HIV, don't go doing invasive fetal monitoring, putting fetal scalp electrode or something that will cause the blood of the mother to enter the baby. No. In as much as they are monitoring, there are other methods we can use to prevent that cross transmission. Okay, so these are numerous methods that we can use to monitor baby, but the one you use depends on an individual basis. You collect the woman, ask questions, check her risk, and then decide what method you want to use for this woman. We're going to go to the external CTG. This is the one that is in vogue now, and we have it in the Limi hospital. It is for continuous monitoring of the fetal heart rate and uterine contraction. It has two probe. One is placed on the fundus to check the contraction, and one is placed on where you hear the fetal heart loudest to listen to the fetal heart. Why I love this is that it gives you, it's non-invasive, and it gives you an interpretation. There is a graph that you can even print, and you can make very good clinical judgment of what is going on with the baby. Okay, it's very sensitive also for detection of fetal distress, and it helps to differentiate low risk and high risk patient. This is usually for high risk patient. If it's a low risk patient, the intermittent auscultation we can manage to use that one for the fetal monitoring. But for high risk patient CTG, like I said, we have it in our hospital almost on every patient throughout the labor. You are strapped to the CTG is strapped to one abdomen, and we do continuous uninterrupted monitoring in labor. So the CTG proper, their basic aspect has baseline fetal heart rate, variability, acceleration, deceleration, and tachograph. The tachograph is the contraction. It's measured in millimeters of mercury, so it's about pressure monitoring of the uterine contraction. So note that CTG cannot make a diagnosis of hypoxia. It tells you that the baby is in distress, but if you want to, hypoxia is a chemical diagnosis, laboratory diagnosis. So when you are using CTG and the baby is saying, I can't breathe, okay, you can go on to now do your sampling, like fetal blood sampling, take blood and measure and determine the level of hypoxemia, and then decide. It can be done between 15-30 minutes interval, and you use it to make decision of what you want to do. Okay, for want of our time, I don't know if I can continue while we wait for the power to come. So for the interpretation of CTG, there is a mnemonic we call Dr. C. Bravado. Okay, thank you so much. It's a normal CTG, but I want to go to this first. Dr. C. Bravado is used for interpretation of the fetal heart tracing. Okay, like I said earlier, if first of all define the risk. Is the patient, the woman, a low risk or high risk woman? Then you look at the contraction. You say the tocodiameter measures the contraction, the strength of the contraction, and you can even watch how many minutes. If you see the CTG, it comes like a graph. Okay, you can choose a segment and decide, okay, I want to read this interpretation over 10 minutes, over 20 minutes, like that. You determine the contraction, the frequency, the strength, the number of contraction in 10 minutes. Sometimes you see a woman contracting back to back, just like I said in my introduction. Okay, the womb, it contracts and it takes 90 to 150 seconds to recover. By the time, imagine 150 seconds, like 2 minutes, right? Yeah, 2 minutes plus. Okay, and you will see that every 2 minutes, imagine a woman is contracting, meaning that she has 5 contractions in 10 minutes. And it takes the uterus 90 to 150 minutes to regain itself. So it means that there is no break, no time for recuperation. Okay, and this reflects on the fetus and it begins to cry that I can't breathe. So you check the contraction, the strength, the number, okay, and then you check the baseline fetal heart rate. You check the baseline fetal heart rate. Sorry. Can somebody help me, please? It's not moving. So you check the baseline fetal heart rate. Baseline is like, this is the normal for this woman. Another person may come and is 120. Another will come is 140. That is the baseline for that baby. Okay, so whatever you are doing, you make reference to it. Like for instance, a baby that has been thriving on 110 and suddenly is reading 150. It's still within normal, but remember, for that baby, it may be a sign of distress. Okay, so that is that about the baseline. So we have our variability. The acceleration is a very good sign, but absence of acceleration doesn't mean that everything is not well. And we have deceleration. So all these things are the things that you see, and then you now decide and make a conclusion on your CTG. The CTG has what we call features of CTG. There are things you see and you say it's reassuring. There are things you see and they are not reassuring. And there are other things you see and you say, oh, this CTG is not abnormal. So I would have shown us the table of how to check. It's something we have to study over time and be able to classify the woman into the CTG into assuring, non-reassuring, and abnormal. So from that, you can also categorize the woman into normal CTG, abnormal, suspicious, and pathological. Okay, for normal CTG, you allow the labor to continue. For suspicious one, you review in 30 minutes or less, depending on the situation. And for the abnormal one, for the pathological CTG, you deliver immediately. I have a graph of abnormal and all those I would have loved to show us about CTG. Then, based on when you have monitored and seen the baby crying, I can't breathe, okay? It tells you there is a danger, and that brings us to intervention. The intervention depends on the stage of the labor. Most times what we do is intrauterine resuscitation, where we put the woman on left lateral position, give oxygen. If there is an offending thing, like maybe she's on augmentation or induction, you stop the oxytocin and all of that. Okay, so these are the things you see, and then decide what to do. If you have done your intrauterine resuscitation and the baby is not, still not breathing well, you have to deliver immediately. Your mode of delivery depends on the stage. If it's a baby that is well advanced in labor, you can do your vacuum forceps, which are available in our center, and also other times we do normal vaginal delivery or a cesarean section, as the case may be. So that is that about the intrauterine fetal monitoring. So as a way of conclusion, intrapartum fetal monitoring remains the mainstay of fetal well-being monitoring during labor. It can be done by auscultation or continuous monitoring, which I had already told us is available in our center. So meconium stem liquor, like I said, is not used in isolation for monitoring of the baby. You have to correlate it with other clinical features of the woman to, determine what to do. So it's in developed countries, continuous fetal monitoring, just like in our hospital, is the mainstay of monitoring. And other biochemical methods are available to assess the well-being of the baby. Thank you so much. And as we have come to the end of my presentation, I wish us to stay put and enjoy the rest of the program. And like we all are here to learn how to make the newborn breathe. So please stay put and enjoy yourself. Thank you.